Good afternoon, class. Good afternoon, class. Can you all hear me? Okay. Now we're looking at some problems with the GIT. We'll be looking at gastroesophageal reflux disease, GERD, and we'll be looking at peptic ulcer disease. Now we want to look quickly at the gastrointestinal tract, which is described as a complex and very important organ system, that has the alimentary canal and then has associated organs like the salivary gland, pancreas, gallbladder, and the rest. Although you have a picture there, but I want to show you something. Okay, this one sort of describe what we're talking about. Starts from the mouth, the oral cavity, esophagus, then to the stomach, small intestine, large intestine, and finally the anus. So you take something in through the mouth and something else is coming out through the anus. The wall of the GI tract is composed of 4 main layers, starting from the mucosa, which is internal, then submucosa, then muscularis externa, and serosa. We are interested in, this is the structure of the stomach. Esophagus now is leading to the stomach. This is what is called the lower esophageal sphincter. There's the upper one. Don't know whether that one is showing in the other picture. Okay, it's not showing, but the upper esophageal sphincter is somewhere here, and it is helping to prevent our food from getting into the throat. I don't know how many of us have wondered, when we are eating or we're swallowing drugs, why is it not going into the windpipe? That is the work of God, natural work of God. So we'll go to our GRD, gastroesophageal reflux disease. Usually it occurs when the amount of gastric juice, which is of course acidic, goes back into the esophagus from the stomach. And at times there could be esophageal mucosa injury, which is termed esophagitis, that is inflammation of the esophagus. So GERD is a digestive disorder, like we said, and is concerned with acid reflux, and the major symptom is a heartburn. And you can confirm that a person has GERD if there is acid reflux or heartburn more than twice a week. Usually there is a burning pain in the chest, which at times some people can interpret to mean ulcer. But then when it becomes something that is regular, like twice a week, and is more on the upper part, not in the lower stomach part, it can safely be guessed to be a GERD. There are some tests that can be done to confirm it, like using the esophageal manometry, which tests the functionality of the esophagus. And then when we are looking at GERD, it can exhibit various symptoms. Some can be classified as typical and some atypical. The typical symptoms actually include heartburn, regurgitation, and dysphagia, while atypical symptoms include what is termed non-cardiac chest pain, that is a chest pain, but that is not related to the heart, asthma, pneumonia, voice changes, hoarseness, and aspiration. If you look at these atypical symptoms, your mind will not go to GERD, but you have to look out for some other symptoms, especially regurgitation immediately after food, and which occurs regularly, at least more than twice a week. And also, of course, the tests that can be done, no laboratory tests as such from experience, but the test that can be done is using the esophageal manometry, and of course, maybe pH monitoring. The pathophysiology, we can look at this through three mechanisms. One is the spontaneous transient relaxation of the lower esophageal sphincter. Normally, is a ring which is supposed to be closing the stomach, content of the stomach from coming up. But when there's transient relaxation and it's not working well, then part of the content of the stomach can come up to the esophagus. Then low resting lower esophageal sphincter pressure and the transient increase in abdominal pressure, especially maybe during sleep or when somebody is bending over. But most times, all this can even occur without resulting in GERD per se. But when it becomes continuous, then we can start suspecting GERD. And we look at the amount of acid and pepsin that is refluxes within a 24-hour period, the length of time that acid or pepsin remain in the esophagus, and the natural sensitivity of the esophageal mucosa. What we say is that normally it's possible that there's a reflux, but it shouldn't be frequent and it shouldn't stay long. You should be able to go back on its own without causing any discomfort or continuous discomfort to the person. Etiology, that is the cause. Mainly cause like movement of acid or acidic content from the stomach to the esophagus. And they can be classified into two: the functional or the mechanical problem. The functional talks about the transient LES relaxation, and the mechanical talks about hypotensive LES. And most of when these are happening and they're taking too long or they're staying too long, then the person can develop GERD. And of course, the transient relaxation can be caused by some food like coffee, alcohol, chocolate. But that doesn't mean that everybody that takes alcohol or coffee or chocolate or fatty meals will have this. Then some medications too can be responsible, and the hormones and nicotine. Some risk factors have been identified for GERD, and these are obesity or weight gain, pregnancy, smoking or chewing tobacco, high fatty meals or large meal portions. That is, if you want to eat, don't finish a big bowl of eba or amala at a sitting, or rice, or your spaghetti, or which other of you students eat? Indomie, beans. So you can eat a little at a time. But some people are lucky, they can eat large meals and without having any discomfort. Caffeine, chocolate, tomatoes or citrus juice. Then you'll be wondering, okay, we are even listing some of these things. But on the other hand, we'll be talking about some of these food being useful to the system. So, but the conclusion here is that everything should be in moderation. Then this GERD can be classified into three: the physiologic, or what is termed functional gastroesophageal reflux, whereby there's no other predisposing condition. It's just that there's a reflux of the gastric content, but it doesn't have any other additional factor or additional morbidity. And in this case, most times the treatment is just a lifestyle modification. Probably if you discover that maybe you eat large quantity, you can decide to be eating your meal in bits. Then also you avoid, lying down immediately after food or bending down. That's why we are advised at times not to sleep immediately after food. We allow some hours before we go to bed. Then it can be pathological, whereby the patient can experience even some complications and there may be need for careful evaluation and treatment. There can be secondary, which refer to a case when an underlying condition predisposed to gastroesophageal reflux. And some of these conditions like asthma or gastric obstruction. Then treatment. The approach to treatment mainly, one, to control symptoms, two, to heal the esophagitis if there is any, and then to prevent recurrent esophagitis or any other complication. And like we have mentioned earlier, most treatment will be based on lifestyle modification and of course controlling of gastric acid secretion, whereby you can use medication to control this. Or if in the worst case scenario, there could be corrective surgery. But most time it doesn't really get to that level. If you can do lifestyle modification and then maybe use drugs that can control gastric acid secretion. So some of the lifestyle modifications, excuse me. Okay. Some of the lifestyle modifications include weight loss if the person is overweight, avoid alcohol or alcoholic drinks, avoid chocolate. But like I said, we should take things in moderation. It doesn't mean you should forgo chocolate completely, but then you limit the quantity you take per time and how frequent you take. Then also coffee, you limit the amount and frequency as much as possible. Avoid large meals. Wait like 3 hours after a meal before lying down. Now I've mentioned that. Then you can also elevate the head of the bed. And of course, avoid excuse me, avoid bending down or stooping positions. And we have mentioned eat small, frequent meals. And of course, if you know you are going to bed like in the next 2 hours, it's better if you have taken your maybe an hour earlier than that 2 hours. That is, take your meal at least about 3 hours before bedtime. Though I know that some of us will be wondering, how is that possible? Because I know that some of us, when we're reading at night, we'll still be munching something. So pharmacologic treatments, we have the antacid. Who can give me an example of antacid? This man, Gascol. And usually this antacid should be taken after meal and at bedtime. Then you can also use or advise our patient to take H2 receptor antagonist or H2 blocker therapy. And these are, they're on the board. Open book question. Okay. These are actually effective in healing mild esophagitis in about 70 to 80% of the patients. Then we can also give our patients proton pump inhibitors. This one, they are quite powerful, and we should be careful in giving them to our patients. They shouldn't be our first line. We start first, like, what did we say we should start first with? No. Before going to drugs. Lifestyle modification. And then when we have to give drugs, we can start with antacid, especially if it is just a mild GLD, whereby this antacid can be combined with lifestyle modification. But it's only when we are not making progress with that patient, then we can go on to the H2 blocker therapy. And if you're still not making much progress, we go to the proton pump inhibitor. But I know that some of us, we want fast treatments, especially if we're in the community practice. You want to give your patient something that, you know, we quickly give them so that they can always appreciate your work. But then but if you look at it, the PPIs are expensive at the same time. So you have to consider that for a patient. But for some people, off record, for some people, the reason why they will give PPI is what? Can you guess? For some practitioners, they give people to increase push market. But then also you need to look at your location. Because if you are located in low-income area, you send them away when you start giving them expensive drugs. So I know that you have to balance ethics, profession, cost, and income as much as possible. Then the last group of drugs are what we call prokinetic medication or reflux inhibitors. This one will, increase the movement of the GIT content. That's moving it off, moving it away. So they don't allow much time for it to be regurgitated. And this one includes metoclopramide, which is popularly known as maxolone, demotilium. Has anybody come across other uses of maxolone? To stop vomiting. Yes. And it's the same process because it helps to move the gastric content further away from the upper part. So it helps to stop vomiting. But then we should be careful for long-term use of these medications. I mean, the prokinetic medications. Even any drug, even our paracetamol, we all know we shouldn't just be using paracetamol anyhow. So every drug, you have to be careful. You have to weigh the benefits to the risk. But so for some drugs, we are told specifically long-term use is can lead to fatal complication for the patient. So we should be discouraged. Any questions so far? Let me even go to the chat too. Okay, somebody is raising the question. What can we say is the major difference between MSCs and GERD? What is MSCs? That should be the first question. Yes, vomiting. Most time with GERD, is not the content will not come out from the mouth. It is sort of just come and get to the esophagus and stay there and causing burning sensation. So we can say that. And then also for GERD, there is acid component involved. But for MSC, it could be maybe the food you have just eaten. It could be anything that can just make you to be nauseated and then you may start vomiting. But with GERD, there is presence of acid. Yes. Excuse me. Okay. Excuse me. I think this person is interested in the fact that when we're saying GERD is like something that is being regurgitated, so it's looking at it from that angle. That, okay, what about MS? Though most time with MS too, there could be acid involvement, especially if maybe it's just after taking food and the food is undergoing digestion. At that time the acid is involved, so the content coming out will involve acid. But when we are talking about GERD, there isn't really vomiting. The patient doesn't even feel like vomiting. It is more of burning sensation. But what's the difference between ulcer? Yes, we are going to get there. Because I have that's my notes. I put it there because I asked myself that question too. That's okay. What is the difference between this portion? Has I have something there. I made a table. That what is the difference between excuse me. We'll come to this figure later. So I just made this table on my own. Okay, let's see what is the difference, because I was thinking, what's the major difference between these two? So can you see? Can you see from this table? In GERD, the acid is in the esophagus, but in PUD is in the stomach lining. Either the upper part of the stomach and then towards the lower intestine. Then also the burning sensation rising from the stomach into the chest or towards the neck is most likely due to GERD. So GERD is more of upper, while ulcer is more of down. So you can see peptic ulcer, however, is typically manifested by symptoms including pain or discomfort localized in the center part of the abdomen. Any other question? Let me go to, I think I'm seeing something in the chat. Oh, okay. Somebody is asking which table. That table is not in your notes. It's a table I created for myself as appendix when I started asking myself that question. So I don't know, can you see it on your screen now? The table is not your notes if you are reading your notes, but it's on the screen now. It's on. Then I can even still scroll down for another table where I was trying to describe difference between proton pump inhibitors and H2 receptor blockers. You may screenshot this one as well. And because of this acid involvement, most times the treatment of GRD is similar to the treatment of ulcer as well. But we are looking at the location now to tell us, okay, this is likely to be GRD and this is likely to be peptic ulcer. Because I'm going to ulcer now, so I want to show us this picture. I'm not sure I have this picture. Okay. You can see the stomach here. You can see location where most likely there's a gastric ulcer and then there's duodenal ulcer. And you can see the esophagus here. The sphincter is somewhere here. So once that sphincter is misbehaving, is not closed properly, then contents here will move up here. But not most time, like I was trying to answer the person asking the difference between MSCs and GRD. The content will just stay in the esophagus. Doesn't go as far as getting to the mouth and coming out in form of vomiting. Okay, somebody is raising up her hand. Alex, come. Well, let me go to the chat first. What does it mean by static? I'm not moving it. Eh? I'm not even moving it now. This one is saying you can't see anything. But I'm doing screen sharing. Let me see what this one is asking. Excuse me. Is anybody with phone there? Anybody online? Okay. Anybody online here? Let me go back to. Sorry? Or you want me to go back? I want to be sure that they're seeing this. Sorry? No, the first one. Okay, she's the first one. Yes. Are you is it sure. Although it's showing your the previous one. Okay, so it's starting. It's not showing this one. No. You have done the screenshot, so you send to them, or I will send this later. So the people in the class are confirming that you can't see the other screen I'm showing, but some of them have done the screenshot. Then also I can send it to you later. It's a different note from the one.
Yeah, you can see the person.
I don't want to close because I don't want to start troubling myself with all this technology and miss the whole thing. Okay. So that means they won't see that shot on the site showing the peptic ulcer and the duodenal ulcer. So they won't see this. Have you taken this one? So the people in the class are doing some screenshot and they will be sending to you. Like I said, I may still send this one to you as addendum or appendix. Peptic ulcer disease. Those of us in the class can mute. Peptic ulcer disease refers to a group of disorders characterized by lesions of the upper GIT, that is particularly the stomach and the duodenum. And it usually starts with the duodenal mucosa and then can go through the muscaris mucosa into the deeper layers of the wall. But actually, it actually starts on the most external. Wow. So there are actually two major types of peptic ulcer: gastric ulcers and duodenal ulcer. Gastric ulcers involve the lining of the stomach, and duodenal ulcer, the lining of the upper part of the small intestine. Okay, I will need to stop sharing this one. Sorry? I want to share that other one that we claim they can't see. Come on. Can you see the new one? And I hope the system is not off. Can you hear? Because I can't even see anything now.
I can hear you, but
okay.
Your screen is not.
Oh, okay. Share screen. Okay. Can we see the screen now? Okay. I just want to show us that picture of gastric ulcer and duodenal ulcer, where it is actually located. This is the duodenum, small intestine, and this is the stomach. Excuse me. Oh, this class. No, just like we mentioned when we're talking about esophagus, that when we eat, it prevents the food from getting to our windpipe. The same thing that God has created in us, everything is supposed to be in balance. It's only when there is imbalance, that is when we start coming up with one disease condition or the other. So under normal condition, there's a physiologic balance between the gastric excuse me, secretion and the mucosal defense. But when there's injury, when there's mucosal injury, peptic ulcer can occur because the balance is now disrupted. So we have what we term aggressive factors and defensive factors. So when there is imbalance between these two, probably when the aggressive factors overpower the protective factors, then peptic ulcer can result. Part of the defensive mechanism include thick mucus secretion by the mucosa. Then there's mucosal blood flow. There's alkaline or neutral biliary juices that help to buffer the acid from entering the duodenum from the stomach. And then, of course, we have prostaglandins that prevent injury by inhibiting gastric secretion. And then the aggressive factors, the non-steroidal anti-inflammatory drugs. We know the non-steroidal anti-inflammatory drugs. Can you give examples, please? Aspirin is already on the board. Give me something, Napa. Okay. Okay, diclofenac and the rest. Then H. pylori infection, alcohol, tobacco smoking, gastric acid, pepsin. So you can see if these aggressive factors, if they suppress the defensive mechanism or protective factors, then peptic ulcer can come up, like I said. Because these aggressive forces, they alter the mucosal defense mechanism. Now we have mentioned some of these aggressive factors, the NSAIDs, the H. pylori infection. So we want to talk about pathogenesis involving the H. pylori, and anyway, H. pylori is endogenous in the system, but the NSAID, we can call them exogenous agent, but eventually it's when we take them and they get into the system that they now cause problem. And there's a sort of complex interaction between these two, that is the NSAID and H. pylori to cause ulcer. Now, H. pylori was called Campylobacter pylori previously. It's a gram-negative bacterium that lives and infects the gastric mucosa. The H. pylori can be spread from person to person via fecal oral routes. And it's been found that for duodenal ulcer, that H. pylori is always present. But for gastric ulcer, about 70% of the cases. So that is why in treating whether it is a peptic ulcer or duodenal ulcer, there is need to eradicate H. pylori. And of course, there are tests that can be done to confirm whether H. pylori is present or not. But most times, because of this information we have, that almost all patients with duodenal ulcer will have H. pylori infection, and 70% of the people with gastric ulcer will have a H. pylori infection. Usually, the treatment involves eradication of H. pylori. Then excuse me, the non-steroidal anti-inflammatory drugs, like you have given me examples, the ibuprofen, diclofenac, they are actually anti-inflammatory drugs, and some of them actually have analgesic properties as well. And we even have indomethacin, but I don't think indomethacin is popular again after it turned out to be drugs used to kill rats. Indocid, yes. And we are told that this NSAID, the way they cause ulcer is different from H. pylori causes ulcer, but there could be complex combination of the two for peptic ulcer. And then when we're looking at the NSAID, there is another group of NSAID that they are called cause inhibitor. Those ones actually don't have much effect in causing ulcer, unlike our diclofenac, indomethacin. Example of the cause inhibitor is celecoxib, and that one does not cause ulcer as much as the other regular or non-selective NSAIDs. And when we're looking at gastric ulcers, it's classified into 4. In 1, it is located near the border between antrum and body of the stomach, and usually the patient with type 1 gastric ulcer will have normal or decreased gastric secretion. While for type 2, gastric ulcer is a combination of stomach and duodenal ulcer. They are associated with normal or increased gastric secretion. With type 1, the gastric acid secretion is normal, but with type 2, it's normal or increased. And then the type 3 are the pre-pyloric ulcers, but they are associated with normal or increased gastric acid secretion. Excuse me. While the type 4 is near the gastroesophageal junction, and the gastric acid secretion is normal or below normal. This is telling us that there's complexity in ulcer formulation or ulcer formation, sorry. So the etiology involves 3 distinct causes. That is, 3 distinct causes are recognized. We've mentioned the Helicobacter pylori, the non-steroidal anti-inflammatory drugs, and then upper secretion of hydrochloric acid as occurs in Zollinger-Ellison syndrome. But then, apart from these 3 distinct causes, there could be other risk factors that can predispose an individual to peptic ulcer disease. And these other risk factors include the previous history of peptic ulceration, genetic factors could be involved, use of corticosteroids, especially when corticosteroid is used in conjunction with non-steroidal anti-inflammatory drugs, cigarette smoking, because cigarette smoking impairs ulcer healing and can promote recurrence or increase the likelihood of ulcer complication. And of course, psychological factors such as stress, student unrest, like the politician will say. stress, not only for, I just use that as an example. Stress, general, okay, Lagos stress, let me put it down. For instance, yesterday I was going a journey of about 15 or maximum 20 minutes. I had to spend 1 hour. And that is still okay. There are times you can spend more than that from here to Akoka. So many stress factors are in Lagos. There are other factors, but which are said to be controversial, that certain food, spicy food, alcohol can predispose to peptic ulcer. Clinical manifestation, that whether it is gastric or duodenal, that they present with similar symptoms. And of course, when a person is standing like this and is complaining, you cannot differentiate between your stomach and the duodenum. So most times, whatever symptoms you bring out, they are similar until maybe a test is actually done to differentiate the two. But usually there will be epigastric pain, which is present in about 80 to 90% of the patients. Excuse me. And it's said that it frequently awakens patients, for duodenal ulcer, it awakens the patients around midnight to 2 a.m. But students that are reading, how are you going to differentiate that? I know that some of you are night crawlers. Anyway, maybe this is Lagos, so maybe people don't read. In those days in Ife, we'll go to the class and read till like 2 a.m. and then walk back to the hostel. Then also it is said that if there is pain within 2 to 4 hours after meals, it's most likely to be duodenal ulcer. And when there is pain, that for duodenal ulcer, food can actually relieve it. But anyway, it depends on the food again. We have mentioned some type of food that can even predispose to ulcer. So you have to be careful of what type of food you are eating, not food that will aggravate it. And it is said that because of the healing effect of food or relieving effect of food, that people with duodenal ulcer usually gain weight because they tend to eat food to relieve their pain. And in that case, they gain weight. But for gastric ulcer pain, that one you feel it within 45 to 60 minutes after meal. So that can be a differentiating factor to determine, okay, this is likely gastric ulcer, this is likely duodenal ulcer. But then but it can happen that somebody may have the symptom maybe after 1 hour, 1.5 hours, and it can still be gastric ulcer. So there may be need to actually do maybe endoscopy to identify which is which. But fortunately, because the treatment is almost the same, then some people will not even bother to go for tests, and especially when you even hear about the cost of the test, rather be taking antacid to relieve the pain. There are some complications that can happen with a peptic ulcer disease, like hemorrhage, and then there could be iron deficiency anemia due to hemorrhage, and of course there could be perforation in some people. So treatment and management. What are the goals of treatment of PUD? Of course, the first thing will be that you want to relieve the symptoms, because the pain can be quite bad. So the first thing the patient will be thinking of is how to relieve this pain. So you want to relieve the pain, you want to reduce the acid secretion that is causing this ulcer and is leading to the pain. You want to promote epithelial healing, and then you want to prevent complications, and of course, you want to eradicate the H. pylori infection. And like we discussed for GERD, we can have non-pharmacological approach to treating peptic ulcer disease. And what will be this non-pharmacological approach? While we can hold on with this non-pharmacological approach. Somebody is saying, this Toluwanimi, that this ulcer thing is stressful. I don't know what he or she means by that. I wish he or she can tell us more. Is it the lecture that is stressful, or is it the ulcer disease that is stressful? Yes, please.
I don't know, but some people, when you experience they see you taking the test. Like right now, like I don't think it's the right thing to take milk. No, you take milk. And I feel like milk is worse in the situation. That's the first thing. Like,
the thing is, I think the reason is that milk is supposed to coat the lining. And maybe that's one of the reasons why, if you want to take NSAID and you don't have food, you are advised to take with milk. But I don't know, it's only maybe if, do you have ulcer? Do you know anybody that has ulcer? You do. You do. You had. Okay, you be a good example. So are you telling us that if you take milk, it doesn't relieve you? It doesn't. What? No, it's just temporary, just to mask the surface at that moment. Then you now need to look for drugs, because maybe at the moment you are having the pain, you don't have access to drug that moment. That's what I feel. So for you, it relieves, but it bounces back. For you, it doesn't. So you said you had it before. So what did you do? Okay, the person that answered is the disease, and maybe because you are stressing yourself as students. So, but in any case, we need to, like we were saying, non-pharmacological approach. We need to avoid stress. We need to avoid cigarette smoking. We need to avoid alcohol consumption or food that can exacerbate it, especially spicy foods.
Okay, and about mine, I most of the time I don't have this indigestion. Even if I eat I will end up like, okay, I'm used to this good texture, well, my food doesn't just step down. I have to stay, wait, drink water to not go.
For like how many hours? Somebody is giving us example in the class that when she takes milk, it doesn't relieve. Then, okay, somebody is asking online that doesn't the milk aggravate the pain? Does it aggravate the pain for you?
No,
but it doesn't relieve it. For you?
For me, I noticed, actually noticed, and you made me go online to check and actually show it there. I noticed that anytime I have pain and I take milk, I have like this immediate relief. It works like soup.
The lining.
And I noticed, okay, and then I eat. Then afterwards, later on, I'll feel the pain again. And there are sometimes, because I like milk, there's sometimes I won't even feel the pain. I'll just take milk. That's how I knew you are grabbing. I'll just take milk normally just to enjoy it. Then hours later I'll feel it. So I had to go online to check like the milk alcohol, and it was shown there that milk alcohol.
I don't take milk, I take honey. I use honey and warm water. That helps for me.
Somebody is asking, as a pharmacy student, how can we avoid stress? Plan your time well. And somebody is sharing with us in the class now that she uses honey and water, warm water, and it's used. And somebody is also sharing with us that after taking milk, the pain will go there, but it will come back after eating. And it's also saying that because he likes milk, when he takes this milk, whether he has pain at that time or not, that is that time that the pain will even be more. But me, I'm just thinking along the line that, okay, if you take milk and then you don't eat, who knows whether the milk is even pushing up your hunger, and you know hunger can predispose you to having this pain, ulcer pain. Yes, please. Sorry? Yes, it has lactic acid, but you know, it's like somebody may have lactose intolerance, and somebody is asking if milk help, what should people who are lactose intolerant take instead? Like I said, somebody has just mentioned honey and warm water, so you can try it. And of course, you can try to reduce your stress. And like a pharmacy student, you may need to plan your time, and don't take it as pharmacy course is difficult, I must do this, I must do that, because even the mere thought is a stress. So as pharmacy students, believe that since you can gain admission, you can pass your exam. Don't let the course stress you or make you think this thing is stressful.
They say because you have you take everything like citrus. I don't know that.
Maybe because of the citric acid.
No.
Somebody is saying that we are told not to take fruit or citrus fruits. So, and we're saying that probably because of the citric acid. Now, pharmacologic approach. Okay, part of non-pharmacologic approach is surgical intervention, but that these ones are generally reserved for complicated or refractory peptic ulcer disease. As for pharmacologic approach, you know, we have said that H. pylori infection is a major cause of PUD, and non-steroidal anti-inflammatory drug. So because of this, one, you have to eradicate H. pylori infection. And then also we want to prevent complications in patients with peptic ulcer. So we have anti-secretory acid anti-secretory agents, the proton pump inhibitors, and the H2 receptor antagonists. Then we have mucosal protective agents like bismuth or misoprostol, and then we have agent that promotes healing through eradication of H. pylori. So treatment involved with the H. pylori, because our time is almost, it's even up. Just give me like 3 minutes, we run through, and since you have your notes. Treatment of H. pylori associated ulcer. We are saying that we want to completely eradicate the this H. pylori by using effective antibiotic regimen. And usually it's a combination therapy, really. So the primary therapy for H. pylori infection is use of proton pump inhibitor based triple therapy, so that this can, you know, cure the infection and heal the ulcer. And this happens in 85 to 90% of cases. Then when we are looking at this, I want to go to that table. This triple therapy is supposed to be used for 7 to 14 days. And it has proton pump inhibitors, has a proton pump inhibitor, has the proton pump inhibitor, amoxicillin and clarithromycin. Then also when we're looking at the proton pump inhibitor, though the table you have in your notes has specific proton inhibitor listed, but it's been found that for any of the triple treatment, for instance, this one that has amoxicillin, clarithromycin and PPI, you can pick any of the PPI, but of course the dose will be different because they have different doses and work for them.
Why did I say we can
Yes, that's another group. There's another one that if the patient is penicillin sensitive, that metronidazole can be used in place of amoxicillin. Okay, this is you can see the table. So what I'm trying to say is that instead of this omeprazole, even you can use lansoprazole in combination with amoxicillin and clarithromycin. It doesn't mean that it must be omeprazole. But what will happen is, if you are using lansoprazole, for instance, it will be 30 milligram BD. It will be 20 milligram BD. So it can use any of the PPI with amoxicillin and clarithromycin. That is it, because you can come across some literature like that. So that's why I'm pointing it out. And of course, maybe in your pharmacy, if you don't have omeprazole and you have lansoprazole instead, you can use. But definitely the dose will be different. So the same thing with this metronidazole and clarithromycin combination. Then if the triple combination is not working, then we can go for the quadruple therapy, which has bismuth, metronidazole, tetracycline, and then either H2 receptor antagonist or proton pump inhibitor. And it's supposed to be given for 14 days. Usually, you don't start with the quadruple therapy. It's only if the triple therapy has failed. That is why when you can go to the quadruple therapy. But it depends. Maybe with advance in science, if it is eventually discovered that the triple therapies are failing generally, they come to the point whereby the patient will just be placed straight on the quadruple therapy. Then for the non-steroidal anti-inflammatory drug-induced peptic ulcer disease, now this will depend on if the NSAID is to be used to continuously. Then there may be need maybe to change the NSAID to the COX-2 selective inhibitor. That is if the patient, like elderly patients now with is it arthritis or something, whereby they need to continue to use the NSAID, they may need to change the NSAID to the COX-2 selective inhibitor. But whereby the patient can stop the use of NSAID, definitely that will be the best thing to do.
Since they're already taking those other drugs that contain the PPI, can't you give them, it's not safe to give them any more kind of medicine?
Sorry?
Like, since they're already taking the proton pump,
okay, the combination therapy.
Can't you give them any NSAID alongside?
No, I don't think it's right, because since we said it's an aggressive factor, you don't want to add aggressive factor to your treatment. It's better to just avoid completely if it can be avoided, so as to maintain the healing process. You don't want to put something that will trigger the ulcer or that will prolong the ulcer and not let the effect of the triple therapy to manifest easily. That is, you want to avoid what can, cause an issue with peptic ulcer disease. But that's why it is said that if the patient cannot stop taking NSAID, there might be need to, change to the COX-2 selective inhibitor, because those ones they don't cause much peptic ulcer disease. So and that's why primary prevention of NSAID in this ulcer will be to avoid unnecessary use of NSAID. Now, if possible, if acetaminophen can be used, that is paracetamol can be used in place of NSAID, the better. But if not, they may need to use the lowest dose. That is, if the patient cannot avoid using NSAID, they can give the patient the lowest dose or give the COX-2 inhibitors. And to reduce the NSAID induced ulcer, the the following regimen is recommended. Misoprostol. Now, there was something that is interesting in this misoprostol. I'm like, it has different uses. It has another that is almost opposite this. And it's even said, when I was trying to check online what is going on, it's even said that the prostaglandins themselves in the body, they also have this opposing effect. In some cases, they help in healing ulcer. In some cases, they cause abortion and other issues. So it all depends on what we are aiming at. At least you make sure that your patient is not pregnant if you're going to use a prostaglandin analog like misoprostol. Then if the peptic ulcer disease is what we can call intractable peptic ulcer, is just coming up and coming up all the time, then there may be need for tests for that patient to be sure that it's not even cancer of the GIT for all you know. And at times there may be need for surgical intervention. So there's no chance.
So the only test that can be done just quickly.
That's one I know. That's one. Then there's a test, I think it's breathing test for H. pylori. But like I said, since we know that for the majority of people with duodenal ulcer will have H. pylori implicated, and about 70% of people with gastric ulcer will have H. pylori implicated. It might just be better to eradicate, to treat with the purpose of eradicating H. pylori infection. But if you want to just to be sure, you can do the test. But by the time you start thinking of additional cost of testing, you'll be wondering, shouldn't it even be better for me to just treat? Any question or contribution? Thank you, our ulcer patients. No, we didn't finish. What did you now do? Because you said you had, and you don't have with me.
I reduced my stress.
Okay. How did you reduce? Was the stress due to pharmacy or something else?
Yeah, it was navigating before.
Okay. So what I'm asking is because some people ask that how can you stop stress in pharmacy? As a pharmacist student, how can we avoid stress? That's the question I'm asking. Okay.
And I used the
Triple.
The triple therapy, the first one.
Okay.
Like my son for 2 days.
Okay. How about you? Have you tried the triple?
Because I've had it for a while. So sometimes it's like throughout last year, I don't think I experienced it.
And because you are not in school last year.
But when I came back, so before we resumed to the hospital, I started having the pain again. And I used because one of my friends gave me pharmacological. So I took it with that's a fast, like once I have it, I don't have the problem because I always have access to it.
But wait, have you tried the triple therapy or the quadruple therapy?
No,
the 7 to 14 days.
I tried the triple.
The 7 to 14 days.
Yes. That's why I said it's fluctuating because now I'm experiencing
That is, you use it continuously for 7 to 14 days.
Because I was not addicted because I had the whole thing, so I completed everything. So since then, I've not been having it like that until now. I started. I noticed that because I will eat and I put nuts. I will digest. Yes. And I will I will be so comfortable if I start having constipation.
Yeah, is it possible to try to identify the type of food that probably cause your indigestion so that I can avoid some food? For instance, recently, I think this one is, you can stop sharing. You can even stop the class. Okay. I heard that is being recorded online. Yeah, but if you like, you can still write because that's what Pharmacologic told me. Somebody is asking, does ulcer cause itching too? I'm not sure about that. Itching in which part? In the throat or in the mouth or where?
No. The only one I know is that you feel the pain to the back. Yes. Like the back. And so apart from the chest, the pain from the stomach, get to the back.
So like I was saying, you may need to observe your meal and see, okay, which meals, because if you try to be observant, you may discover that some meals are responsible and some may not really cause you discomfort. But if you're still not satisfied, probably you need to see your gastro doctor. Coming to, I'm even thinking of seeing a gastro doctor because recently I discovered that I don't have much appetite for some food. Merely looking at that food make me feel like vomiting. But meanwhile, some other type of food, I don't have problems. So when I complain to a friend, I've been complaining to doctors, nurses, and I told me, well, eat what you are comfortable with. Simply. And of course, anyway, the food that is causing me wahala self, I can afford not to eat it. So that's I'm sharing that experience. That maybe try to be observant and see which food actually gives more problem. Then you can avoid them if possible. But if you're still not satisfied, you're not getting it, then it's better you see a gastro doctor. So thank you everybody for coming to class. We'll meet again maybe next week. I think I still have malnutrition or something. Yes, protein energy.